Hi, I'm Tracy Madsen. I'm here today with Dr. Lesli Skolarus and Elder Sarah Bailey talking about their study, Stroke Ready. Welcome.
Thank you.
I'm really excited to hear about Stroke Ready. Can you tell us a little bit about the purpose of the study?
Well, the purpose of this study was to actually reduce and to reduce stroke negative outcomes amongst our community members, and to also educate African Americans in Flint regarding the signs and symptoms of stroke. And it wasn't that this was not already being done. It's just that when it comes to getting the attention of African Americans, when your material does not show them in it, what happens is that they dismiss it and say that that's not for them. So our design was to actually bring materials to them that showed that African Americans actually had strokes, but also could benefit from understanding what they needed to do.
That's wonderful. How did you do it? How did you do the study? Can you describe that a little bit?
Yeah, so we had two parts. So we first optimized care in an emergency department, in a safety net emergency department. That was sort of like phase one. And then phase two was we conducted a community intervention led by stroke peer leaders who were trained peer leaders in the community who went out and disseminated stroke preparedness. We initially started out just with stroke preparedness, and we heard from the community and our community partners but the hospital's not ready to treat us.
That's right.
We're going to call 911 and nothing's going to happen. So we decided that we needed to do both components were really important.
Great. And what types of education in the community did you do? What types of things did you teach community members about so that they could get to the hospital in time to get treatment?
So I think we did two things that we're really proud of. One, we really focused on stroke self-efficacy so that you could do this. And during a lot of our workshops, we would have people practice calling 911 or practice recognizing a stroke and thinking like role play, like these are the questions you're going to be asked. This is how you would respond to sort of gain that confidence that if this situation ever arose, that they would be ready for it. And I think the second thing is that we worked with the community and our community partners to identify community-specific barriers to calling 911.
Okay.
So thinking about cost, thinking about insurance, thinking about delays in EMS, and we had specific sort of community-tailored responses to each of those challenges that the community identified to make it to at least decrease the concerns that we could actually calling 911 was the effective thing to do.
Right. This is such a unique study. I think we've seen a lot of studies that have done educational interventions and tried to measure self-efficacy, but to have patients actually role-playing and actually addressing the specific barriers that they might face when they're considering calling 911 for a family member is really wonderful.
Thanks.
How did you measure your outcome? What kind of outcomes were you looking to achieve?
So our primary outcome was IV thrombolytics, and we decided that we had a series of preliminary pilot studies where we measured more behavioral intent or self-efficacy, but at this stage, we felt like we were ready to really measure thrombolytics. And then we measured many other outcomes. We obviously measured endovascular treatment as well. It got a little tricky because during our study, actually, the indications for endovascular treatment really changed. They really expanded. And so when you're doing a time series analysis, that's a huge barrier. And so we ended up, our primary outcome of IVTBA.
Wonderful. Were you able to also look at things like percentage of people who used EMS or time that it took people to get to the hospital?
Yes, we measured EMS arrivals.
Okay.
But we did not measure symptom onset to arrival time. We tried to capture that data, but honestly, we didn't believe the validity of it. And so we ended up thinking that we had to buy a sample of responses.
I see. And what did you find? What were your study results?
So we found that overall stroke rating did not increase thrombolytic treatment rates. When we looked at it in its components, the ER component, so optimizing care in a safety net emergency room, seemed to increase thrombolytic treatment rates, while the community intervention was non-significant. We then kind of stepped back and took a broader approach of what did thrombolysis look like in FLIT in general, and outside the intervention. And we did see that at the start of the decade, so at the start of 2010, Black people were much less likely to be treated with thrombolytics than white people. And that racial disparity decreased or even reversed at the end of our time period, at the end of 2020. So to us, that was like so encouraging to think that like it's possible. Like I think sometimes we think that like racial disparities are so entrenched and there's really nothing, we become fatalistic, like there's nothing we can do. And this is like a terrific example of like, we can actually do this. Well, a whole community actually did this.
That's amazing. What types of things were you doing in the emergency department that you think could have contributed to the reversal of that disparity?
So we did, we had an audit and feedback intervention that we did. We had a learning health collaborative where we provided external support to sustain. And then after that, the hospital itself made many changes, in itself. So it started QI in itself. It did a lot of training. It did some workforce changes where they had basically a super stroke nurse come down, which they modeled after their trauma program, which they had. And then they did a door to CT program as well. So they themselves did a lot of changes after that were kind of motivated by this audit and feedback system.
I see. That's wonderful. And do you plan to expand those programs, so either the ED portion or the community portion, to other communities in Michigan, or what are your next steps?
Yeah, I mean, I'm excited about the ED intervention. I mean, I think we could work with low performing, high volume EDs and to sort of implement this bundle and see if we can, really test it in a cluster randomized trial. The community intervention, I have to admit, was a little disappointing. We were hoping for a larger effect size so I think, we're back to the drawing board on the community piece. Like, we would ask the viewers of this to contact us, and any of you have ideas, because I think that, we haven't really cracked the code of community stroke preparedness yet.
Do you have any things kind of off the top of your head that you would change about the community portion, or things that were more challenging than you expected when doing the work in the community?
Yeah, I think part of the thing is that you've got a community like Flint that has undergone numerous crises, one right after the other, which impeded a lot of people from actually focusing in on what we wanted to do. We have a water crisis still going on, even though everybody thinks that water crisis is over. It is not. We have a pandemic. In the midst of that, that people are more focused in on. So when it came down to being focused on looking at their health in terms of stroke or the preventatives to stroke, people were less likely to focus there as these other issues came to the forefront. So one of the things that I'm concerned about and I want to be able to do now within the community is to come back to the community and say to the community, now that we're starting to see some movement towards a reconciliation with the water crisis as well as with the pandemic, now let's go back and let's focus again on getting your health into the place where it needs to be. And that means you have to understand and know. And I think the pandemic sort of brought that home to a lot of people, that there are comorbidities that they have to take charge of. And so that's what we want to do with the community. I think that might be helpful with them.
It sounds like you learned a lot and made it through a lot of challenges during this time.
We have, and we did, and we will continue. We're a resilient community. And when it comes to anything else, I think we have to be able to show that you can translate this from a community like Flint to other communities. And but they also may be experiencing that. And Lesli and I talked about, Dr. Skolarus and I talked about her going to Chicago. And I said, it's wonderful, because Chicago is nothing more than a series of little communities like Flint that call themselves Big Chicago.
That's great. You'll have a lot of little communities to work with in your new role. Is there any advice you would give other communities or other hospitals or other physicians or teams of people who are caring for those with stroke? Any advice you would give them for trying to implement something like this?
I think that we share the thought of like just the power of community engagement. I really think that like there is a force multiplier effect of academics working with community members in true partnership, like from the beginning. Well, let's identify what we're going to do. How are we going to address this? What speaks to you? What materials speak to you? How can we raise community capacity to such that when the researchers leave, like the community is left much better than before the researchers came in. So I think that like we're motivated to do things like this and to talk, because like we really believe that this approach to health equity and to stroke and stroke research is really, critical to moving forward.
Well, congratulations. This is such a great example of partnership between researchers and community and really focusing on brain health and stroke. So congratulations on all the work. It's really amazing.
Thank you. Thanks for having us.
No problem.